we have to infiltrate the local anesthetic. It will only anesthetize that area of the body where we need to anesthetize the pain sensation or touch sensation, etc. So local anesthetics are drugs which on topical application or which on local injection can cause reversible loss of sensory perception in the restricted region of the body. So when we give local anesthesia, either it is applied topically or it can also be given through the local injection, and so when it is given it cause the reversible loss of sensory perception. That is, when we give the local anesthetic, it will anesthetize that area for certain period of time, and then after certain time it will the sensation will be reversed back, and this local anesthesia will only anesthetize the certain restricted region of the body. And local anesthetics, they blocks the generation as well as conduction of the nerve impulse at the localized site of contact without structural damage to the neuron. So when it is given, it will block the conduction and generation of the nerve impulse where it is injected, and it doesn't cause any damage to the neurons. And when we give local anesthetics, it will block the function of nerve, and the order in which it will block the functions of the nerve are, first of all it will block the pain sensation, and after pain sensation it will block the temperature, then gradually it will block the touch sensation, pressure, and finally skeletal muscles power is decreased. So first of all, whenever we give local anesthetic, it will first abolish the pain sensation followed by temperature, touch, pressure, and finally skeletal muscle power. So whenever we are doing some surgical procedure or OPD short procedure, whenever we inject local anesthetics, we'll wait for 2 to 3 minutes, and then we'll pinch the skin of that area, and we'll ask the patient whether you feel the pain sensation or not. Okay, we'll just prick or pinch in that area, and we'll ask the patient whether he can feel pain or not. So here comes the classification of local anesthetic drugs. So local anesthetics, there are two types of anesthetic. One is injectable anesthetic and another is the surface anesthetic. So in injectable anesthetics, there are certain drugs which has low potency and it also has a shorter duration of action. So those drugs which has low potency and has short duration of action is procaine and chloroprocaine, whereas those having
Ma'am,
azure. Yes,
ma'am, slide change भएको छैन
भएन.
छैन म्याम
ओके, सो म फेरि एकचोटि रिजोइन गर्छु ल, नेट स्लो भएर होला. Potency and duration, intermediate duration are lignocaine and prilocaine, whereas those having high potency and long duration of actions are tetracaine, bupivacaine, ropivacaine, and dubicaine. Whereas in surface anesthetics, there are two forms: soluble form and insoluble form. And soluble form contains cocaine, lignocaine, tetracaine, and proparacaine, whereas in insoluble anesthetic it contains benzocaine, butyl aminobenzoate, and oxytazine. So in local anesthetic, the most common drug which we use in clinical practice is lignocaine. It is the most common form, and after that we commonly use bupivacaine in the clinical practice, and other drugs are not that commonly used. So coming to mechanism of action of local anesthetics. So local anesthetic, it usually blocks the sodium voltage gated sodium channel, and it blocks the sodium channel. So consequently, it also blocks the conduction of nerve impulse by reducing the permeability of sodium ion during the depolarization. That is, it will block the voltage gated sodium channel, and it doesn't allow the sodium to enter inside the channels during the depolarization. So when there is no entry of sodium, So there will be no generation of action potential, and so when there is no generation of action potential, there is no generation as well as no conduction of impulse in central nervous system, and it will provide local anesthetic effect. So lignocaine, it diffuses through the cell membrane and it binds to voltage gated sodium channel, and consequently it will block the entry of sodium into the cells, so it raises the threshold for excitation. There will be no generation of action potential, there is no generation
Ma'am,
and hazard.
म्याम फेरि अड्क्यो
हो र
म्याम त्यो स्लाइड सो नगरिकन त्यो उबाटै गर्दा अड्किन्न होला
अहिले
अहिले इफेक्ट अफ पिएचमा पुग्यो
अहिले कहाँ पुग्यो?
अहिले बल्ल आयो
म यसरी नै पढाउँछु र त्यसो भए
हुन्छ
Okay, so lignocaine, it will bind to voltage gated sodium channel and it will block the entry of sodium into the cell. So there will be no formation or there will be no generation of action potential. And then there will be no generation or conduction of impulse in the central nervous system, finally leading to local anesthetic. So the main mechanism is it will block the voltage gated sodium channel and it does not allow the sodium to enter into the cells, so there will be no conduction of impulse in the CNS and it will provide local anesthetic effect. So there are local anesthetic has some effect on pH. So local anesthetic action is strongly pH dependent. It depends upon the pH of the pH, and then the penetrability is increased at alkaline pH and less at acidic pH. So local anesthetics, it has increased permeability or increased penetrability in the alkaline pH, whereas it can penetrate less in the acidic medium. So the local anesthetic, whenever it is in unionized form, it will easily penetrate the nerve sheath and the axon membrane, and after entering into the axon, then it will become or it will change into ionized form and it will block the voltage gated sodium channels. So local anesthetics are less effective in infected and inflamed tissue. Why? Okay, so whenever we give local anesthetic, so it is less effective whenever there is infection or whenever there is some tissues are inflamed, then it has less action. Why does it has less action in infected and inflamed tissue? So it has less action because in infected area the extracellular pH is acidic. So I already told it will have more penetrability or permeability in alkaline pH and it has less penetrability in the acidic pH. So in at the site of infection, the extracellular pH is acidic and the local anesthetic remains in ionized form that result in poor diffusion through the nerve. That's why it has less effect in the infected tissues and the blood flow to the inflamed area is increased. So the local anesthetic is removed more rapidly from the site. So whenever there is infection or whenever there is inflammation in any area, there will be more blood supply in that area so that the inflammation area or infected area can get enough oxygen and it can be healed soon. So whenever there is increase in blood flow to that area, what happens when we inject the local anesthetic in that area? Due to increase in blood flow to that particular area, the drug will be removed more rapidly from the side. So local anesthetic drug will have decreased effect in the inflamed tissue. And the inflammatory products that are present in the infected area may oppose the action of local anesthetics. For like whenever there is infection or inflammation, there may be various inflammatory mediators that are present in that area. So those inflammatory mediators like cytokine, prostaglandin, etc., they will oppose the action of local anesthetic drug. So there will be decreased action of local anesthetic drug in infected area. And last point is the effectiveness of adrenaline injected with local anesthetics is reduced at the inflamed site. So in our clinical practice we usually we give local anesthetics along with addition to adrenaline, which is a vasoconstrictor. So in clinical practice we usually mix adrenaline with local anesthetic, and in some cases only we use local anesthetic alone. So when local anesthetics is given with adrenaline in case of in the area where there is infection, the effectiveness of adrenaline is reduced in that area. So why do we give adrenaline along with local anesthetics? So what is the advantages of giving the local anesthetics along with vasoconstrictor, that is adrenaline? So what are the advantages of giving these two drugs in combination? So whenever we give these two drugs in combination, the advantage is number one is it will prolong the duration of action of local anesthetics by slow absorption from the local site and decreasing the rate of removal. That is, whenever we give adrenaline, since it is a vasoconstrictor, it will constrict the blood vessels. So when it is given along with local anesthetic, there will be, due to vasoconstrictor effect, the drug will be slowly absorbed from the local site, so that the duration of action is also prolonged and the rate of removal of drug is also prolonged, and gradually the contact time of local anesthetic with the nerve fiber is prolonged. So number one is it will prolong the duration of action of local anesthetics due to its vasoconstrictor effect. And number two is it provides a bloodless field for surgery. Whenever there is some patient comes to emergency with some cut injuries with heavy bleeding, we while applying the suture we give adrenaline along with local anesthetic, because adrenaline it will constrict the blood vessels and it will reduce the bleeding in that area. So whenever we try to suture that area, it will provide a bloodless field for the surgery. So this is another advantages of giving adrenaline along with local anesthetics. And number three is it will reduce the systemic toxicity of local anesthetic due to slow absorption. So whenever it is given in combination with adrenaline, the local anesthetic is absorb very slowly, so that systemic toxicity is also reduced. So this is another advantage of giving it in combination. And it will enhance the intensity of the nerve block. So when it is given together, it will increase the intensity of nerve block in that particular area. So these are the advantages of giving local anesthetics along with vasoconstrictor drug, that is adrenaline. Now, what are the disadvantages of combining these two drugs, or what are the contraindication of combining these two drugs? So, whenever these two drugs are given in combination, it may cause gangrene of the organ having end arteries due to intense vasospasm and ischemia. So, what are the body parts, or what are the organs where we cannot use local anesthetics along with vasoconstrictors? Are fingers, toes, penis, ear lobule, and tip of the nose. These are the organ which are having end arteries. So what happen in end arteries? So in end arteries, the artery will end on that organ. There will not be any collateral blood vessels. So when we give local anesthetic along with vasoconstrictor drug, these arteries will be constricted. So there will be no blood supply to those area having in arteries. So whenever there is no blood vasoconstriction, and whenever there is no blood supply to those area, due to vasospasm, those area will go into gangrene, or there will be ischemia in those area, and those part will have gangrene in that area. So due to increased vasospasm and ischemia in the organ having in arteries, it may cause gangrene. So we have to avoid giving these two drugs in combination while doing surgery or any procedure in those area which has in arteries. So these two drugs are contraindicated in these organs. Now, another is absorption of adrenaline can cause systemic toxicity like tachycardia, palpitation, rise in blood pressure, precipitation of angina or cardiac arrhythmia. Hence, combined preparation is contraindicated in case of hypertension, congestive cardiac failure, or ischemic heart disease. So, adrenaline being vasoconstrictor effect, it will cause tachycardia, palpitation, it can increase the blood pressure, it can precipitate angina. So these two combination has to be avoided if the patient is hypertensive, if the patient is having past history of any heart diseases or ischemic heart diseases, etc. Now, next is it will delay wound healing by reducing blood flow and reducing oxygen supply to that area. So, due to vasoconstriction, there won't be enough oxygen supply, or there won't be enough blood supply to certain area of the body due to vasoconstrictor effect of adrenaline. So, if there is decrease in blood supply, there will be decrease in oxygen supply. So, the wound healing will be decreased. So, these are the disadvantages or contraindication of combining local anesthetics along with adrenaline. Now, coming to pharmacological actions of local anesthetics. So, local anesthetics can affect various system of the body. So, coming to nervous system. So, in peripheral nerves, the order of blockade of nerve fiber, as I had already told, the order of blockade of nerve fiber are autonomic fiber, and first there will be abolish of pain sensation followed by touch, temperature, pressure, and motor fibers. Whereas in central nervous system, these local anesthetic, it can cross the blood-brain barrier, and after crossing blood-brain barrier in the initial stage, it can cause CNS stimulation followed by CNS depression when it is given in higher doses. So they may cause, due to CNS stimulation, they may cause excitement, tremors, twitching, restlessness, and convulsions. And when it is given in higher dose, it can cause respiratory depression, it may lead to coma, and finally there may be death of the patient. So it should not be given at higher dose because it may cause respiratory depression and sudden cardiac arrest also. Now coming to cardiovascular system, in heart, at when it is given at higher dose on intravenous administration, it may cause cardiac arrhythmia. And among the local anesthetic, bupivacaine are more cardiotoxic than the local anesthetics like lignocaine, and it may cause cardiovascular collapse and finally death. And but lignocaine has little effect on contractility and conductivity, and it is also useful in ventricular arrhythmia. So whenever we see a patient with ventricular arrhythmia, we can give certain antiarrhythmic drug to treat the patient. But sometimes what happens in emergency or in ICU or CCU, you can see whenever patient is having certain ventricular arrhythmia, sometimes what does physician do? They will inject the lignocaine injection directly into the heart. They will give injection directly into the heart, so that there will be decrease in the ventricular arrhythmia. So in that case, uh, lignocaine can also be used to treat the ventricular arrhythmia. Now coming to blood vessels, uh, lignocaine, it produces fall in blood pressure due to vasodilatation and myocardial depression. That's why patient may have hypotension when they are given local anesthetic drugs. Now, coming to adverse effect of local anesthetics. So, local anesthetics may cause CNS effect like lightheadedness. It can cause dizziness, auditory and visual disturbances. Patient may be confused, disoriented. There may be shivering or twitching, followed by convulsions, and sometimes patient may also have respiratory arrest leading to death. And coming to cardiovascular toxicity, it may cause bradycardia, it may cause hypotension due to vasodilatation. Patient may have cardiac arrhythmia, asystole, and vascular collapse. And Lignocaine local anesthetic injection, while injecting it is also very painful, and it also impairs the wound healing because it may constrict the blood vessels so that there is no adequate blood flow to that area, or there may be decreased oxygen supply to that area, leading to delayed wound healing due to injection of local anesthetics. Now, uses and techniques of local anesthetic. So, what are the uses? What are the conditions where we can use local anesthetic drugs, and what are the various techniques we applied for having local anesthetic effect? So, number one is surface anesthesia, which is also known as topical anesthesia. So, surface anesthesia name itself says it is applied locally. So it is surface anesthesia. It is produced by topical application of a surface anesthetic to mucous membrane or abraded skin. So the drug is applied superficially to anesthetize that particular area, and only superficial layer is anesthetized, and there is no loss of motor function. So since it is applied topically, it will only anesthetize the superficial layer, but motor functions are not affected, and onset and duration of action depends upon the site, drug concentration, and form. So it depends upon the site of application, in which site the drug has been applied, and what is the concentration of the drug, and in which form the drug is given. Either it is given topically or in injectable form. So it depends upon the site, concentration, and form of the drug. So sites of the surface anesthesia are, so surface anesthesia which can be given topical, and those sites are like we can use it topically in eyes, ear, nose, mouth, throat, esophagus, urethra, in anal canal. So for eyes, during we can use eye drop as a local anesthetics. So it can be used while doing tonometry to see the intraocular pressure. In case of glaucoma, we can use it as an eye drop, and similarly ear, nose, mouth, throat, like in throat and esophagus we usually give lignocaine or lignocaine spray, usually while doing endoscopic procedure, and in urethra during catheterization of the patient we use lignocaine jelly. We put into the urethra, and then we, after putting lignocaine jelly, we put catheter in the patient. Whereas in anal canal, while doing rectal examination, we give ointment, lignocaine ointment, and then after applying the lignocaine ointment, we do rectal examination, or while doing colonoscopy also we can use those uh, jellies. And surface anesthesia can also be used in diagnostic procedure like tonometry, I already told, during endoscopies, etc. And various forms of uh, surface anesthetics are, it may come in solution, it may come in ointment, cream, spray, and drop. So these are the jellies we can use, and this is the spray. We usually use this spray while doing endoscopy. Now coming to another form, that is infiltration anesthesia. So what does infiltration anesthesia means? So here local anesthetics is injected directly under the skin in the area of operation so that sensory nerve endings are blocked. So here local anesthetics are directly injected under the skin where we need to do operation, and the onset of action is very quick, immediate, and duration of action is short, lasting for 30 to 60 minutes in case of lignogen. So we have to finish the procedure between 30 to 60 minutes. Otherwise, if the procedure is prolonged, patient may feel pain. So if the procedure is prolonged, after 60 minutes, we have to again inject the local anesthetic so that patient will have loss of sensation in that particular area. And it is used for minor operation like incision, excision, abscess drainage, hydrosis. So for example, if the patient is having some abscesses, and if we have to drain the abscess, we can give infiltration anesthesia directly into that particular area, and it is suitable only for small areas to be operated, and relatively larger amount of drug is required to anesthetize the small area. So this is the infiltration anesthesia. Now coming to conduction block anesthesia. So in conduction block anesthesia, the local anesthesia is injected around the nerve trunk so that the area distal to the site of injection is anesthetized. So in conduction block anesthesia, there are two types of conduction block. One is field block anesthesia and another is the nerve block anesthesia. So in field block anesthesia, local anesthesia is infiltrated around the border of the surgical field. Okay, so it is the drug is given around the border of the surgical field, leaving the operation area undisturbed. Okay, so in the center there will be operation area, and local anesthetics are infiltrated around the border of that surgical field, leaving the operative area undisturbed. So, local anesthetic is injected subcutaneously in the surrounding area of the nerve so that all other nerve which comes to that particular field are blocked. Okay, so anesthesia will start 2 to 3 centimeter distal to the site of injection, and dose required in the field block is less and the duration of action is prolonged. The for field block, for example, we can apply field block for certain dental procedure. We can apply field block while doing suturing or stitching of the scalp, or while operating the forearms and legs. And generally, lignocaine with shorter duration of action is most commonly used. And if the operation is long lasting, then we can use bupivacaine in place of lignocaine. So this is the example of field block anesthesia. So it is usually given for dental procedures. So here local anesthetic is deposited towards the large nerve terminal branches. So this arrow shows the point where we anesthetize, where we give the injection, and treatment is done away from the site of local anesthetic injection. So if it is injected here, the treatment can be given distal to that, and maxillary injection administered above the apex of the tooth to be treated are properly referred as a field block infiltration. So this is how it is done. Now coming to nerve block. So in nerve block anesthesia, it is achieved by injecting local anesthesia very close to or around the appropriate nerve trunks or plexus. So in nerve block, it is given injection is given very close to that nerve which has to be blocked, and it produces larger area of anesthesia as compared to that of field block. So it will anesthetize the larger area in case of nerve block, and muscles supplied by those nerve are also paralyzed in case of nerve block. So here you can see the picture where radial nerve is blocked, and I think this patient is having Cooley's fracture, that is a fracture of the distal end of the radius. So while reducing the fracture manually, we can give radial nerve block so that this the muscle supplied by radial nerve and this area is fully anesthetized, and the uh, fracture can be treated. So frequently performed nerve blocks are lingual nerve, ulnar nerve, femoral nerve, brachial plexus nerve, cervical nerve, facial nerve, or trigeminal nerve. For example, brachial plexus nerve. When we block the brachial plexus, the drug is injected close to the brachial plexus, and it will temporarily block the sensation and ability to move the upper extremity. And patient will remain awake in this case. So whenever if the patient has come to emergency with, for example, shoulder dislocation, the shoulder is dislocated and we have to relocate the shoulder in its original place. In such case, we will do a nerve block of brachial plexus. The brachial plexus will be blocked, and patient shoulder dislocation is reduced and it is relocated into the original place by doing nerve block of the brachial plexus. So nerve block anesthesia, it abolishes the pain and other sensation in that area. Now coming to spinal anesthesia. So what is spinal anesthesia? It is one of the most popular form of anesthesia, and here local anesthesia is injected into the spinal subarachnoid space, and usually it is given in between lumbar vertebra 2 and 3, or it may be in between lumbar 3 and lumbar 4 vertebra. That means injection is given below the lower end of the spinal cord. So in spinal anesthesia, lumbar puncture is done either in between L2 L3 or between L3 L4, and the primary site of injection is the nerve roots in the quadra equina. And spinal anesthesia, the level of anesthesia will depend upon the site of injection. So level of anesthesia will depend upon the site of injection, where it is injected. Either it is given between L2 L3 or between L3 L4. Okay, so it depends upon the site of injection. It depends upon the volume of drug and the speed of injection. How, and it depends upon the volume, how much drug it is given, and it also depends upon the speed of injection, and it also depends upon specific gravity of that drug and the posture of the patient. So while giving spinal anesthesia, sometimes patient are given spinal anesthesia or patient are given lumbar puncture is done in sitting position, and sometimes patient is given injection in supine position or in left lateral position. So depending upon the posture of the patient, also the level of anesthesia depends upon. So the duration of spinal anesthesia depends upon the drug which is used, and it also depends upon the concentration of that particular drug, and it is also given along with adrenaline. So addition of 0.2 to 0.4 milligram of adrenaline to local anesthesia prolongs the spinal anesthesia by about one third, and adrenaline enhances the spinal anesthesia by reducing spinal cord blood flow or by its own analgesic effect, which is exerted through the spinal olfactory adrenoceptor. So spinal anesthesia, it is also given during the pregnancy, like while doing cesarean section. So during the late pregnancy, the amount of local anesthesia is very less amount of drug can be given during later part of the pregnancy, because during pregnancy the inferior vena cava is already compressed with the gravid uterus, leading to decrease in the subarachnoid space. So during the last trimester of the pregnancy, the gravid uterus will compress the inferior vena cava. So whenever inferior vena cava is compressed, the subarachnoid space is also reduced. So lesser amount of drug can be given during late pregnancies. Now this is how spinal anesthesia is given. So here patient is in sitting position, and this is the spinal needle, and it is inserted in the lumbar vertebra, and after when this needle is inserted, we'll feel the prick, or we'll feel the prick inside the spinal cord, and we can see uh, cerebral spinal fluid CSF coming through this needle, and we can be sure that it is injected in the right place. So CSF fluid will be coming out. So if in case of meningitis, for diagnostic procedure also we do lumbar puncture, and CSF examination is sent to see the type of meningitis. And while giving the spinal anesthesia, after seeing the clear fluid coming out, we'll inject the local anesthetics and we'll anesthetize the patient. So what are the uses of spinal anesthesia? In which case we can use spinal anesthesia? So it can be given for operation of the lower limbs if there is if there is fracture of shaft of femur, or there is dislocation of the hip which has to be relocated. In that case we can use spinal anesthesia. And pelvis and lower abdominal surgeries like during cesarean section we can use it, during certain operation procedure and surgery of the perineal area we can use spinal anesthesia. It can also be given during appendectomy and while doing surgeon or certain orthopedic surgeries of pelvis, hip, femur, knee or joint replacement, and it can also be given while doing transurethral resection of prostate in case of benign prostatic hypertrophy in case of old age patient, or while operating the patient who are having cancer of prostate. So we can give spinal anesthesia in these cases. Now, what are the advantages of spinal anesthesia over general anesthesia? So, spinal anesthesia is safer as compared to that of general anesthesia, because in general anesthesia, patient is completely paralyzed. Here, patient is not paralyzed. Patient is still awake. Patient will be awake and patient will be knowing what is going on with the patient. He is not paralyzed, so it is safer, and there is no loss of consciousness in case of spinal anesthesia. It produces good analgesia and it produces good muscle relaxation also. And cardiac patient, pulmonary, renal disease and diabetic patient can tolerate spinal anesthesia better than general anesthesia. In case of general anesthesia, patient is paralyzed, patient has to be intubated, but here in case of spinal anesthesia there is no need of paralyzing the patient and no need of intubating the patient, so it is safer as compared to that of general anesthesia. Now, what are the complications of spinal anesthesia? So the most common complication or adverse effect of spinal anesthesia is the post-spinal headache. Most of the patient, about 90% of the patient having spinal anesthesia will complain of headache, okay, which is known as post-spinal headache. And this headache is due to leakage of cerebrospinal fluid, and it can be reduced by using very fine needles. So when we do lumbar puncture in patient, if we are using a large bore needle or wide bore needle, what happens? When we use large bore needle, a large amount of cerebrospinal fluid will be leaking outside. So, due to excessive leakage of CSF fluid, patient will complain of headache, and this headache can be reduced by using the fine needle, very fine needles. In this way, we can prevent the headache during the spinal anesthesia. And another important adverse effect or complication is hypotension. So hypotension in this case is due to blockage of sympathetic vasoconstrictor outflow to the blood vessels. Here venous return to the heart is reduced due to paralysis of skeletal muscles in the leg. So whenever we find the patient having hypotension after spinal anesthesia, what do we have to do is we have to raise the foot end of that patient, which will overcome the hypotension by promoting venous drainage. And another important thing you have to remember is after after doing lumbar puncture or after giving spinal anesthesia, we have to advise the patient to lie in supine position and not to move head or not to raise the head end of the patient at least for 24 hours. We have to tell patient do not use pillow while sleeping for at least 24 hours of spinal anesthesia or 24 hours of lumbar puncture. Head end of the patient should not be raised. Patient should lie in the supine position and patient should not use pillow to prevent from headache in case of lumbar puncture or in case of spinal anesthesia. And coming to another point is respiratory paralysis. So here the respiratory paralysis is due to paralysis of intercostal muscles, and hypotension and ischemia of respiratory center may lead to respiratory paralysis in case of spinal anesthesia. And it may also cause neurological symptoms like pain and paresthesia in the back, and lower limbs may be there, but there may not be any neurological deficit. Patient may complain of anesthesia, and patient may complain of numbness in the lower limbs and back. And another important and rare complication is known as quada equina syndrome. So quada equina syndrome, it occurs when the nerve roots of quada equina are compressed, and it will disturb the motor and sensory function of the lower extremities, as well as bladder and bowel habits. So it is a rare condition leading to prolonged loss of control over bladder as well as bowel sphincter. So patient having quada equina syndrome will have incontinence of the urine, as well as fecal incontinence, and it may be due to traumatic damage to the nerve root of quada equina. And sometimes patient may also complain of nausea and vomiting after spinal anesthesia. Now, what are the contraindication of spinal anesthesia? So, spinal anesthesia should not be given in the patient who is having hypotension and shock, because in hypotension and shock patient is already having lower BP. So if we give spinal anesthesia due to local anesthetic effect, there will be further vasodilatation leading to worsening of hypotension. So it is contraindicated in case of hypotension and shock, and it should not be given to the patient who are very uncooperative and mentally ill patient, because while giving spinal anesthesia, uncooperative patient may move, or mentally ill patient may move, and we can puncture the spinal cord leading to bleeding. So it is avoided in uncooperative and mentally ill patient. It should not be given in case of infant and children for the same reason, and it should not be given for bleeding disorder because there may be chance of excessive bleeding, and it should not be given in case of raised intracranial pressure, because if the patient is having raised ICP, patient already has headache due to raised intracranial pressure. So if we give spinal anesthesia, there will be leakage of cerebrospinal fluid, which will again give rise to increase in the ICP, worsening the headache again. So we have to contraindicate giving spinal anesthesia if the patient is having raised intracranial pressure, and it cannot be given in the patient having vertebral abnormalities like kyphosis, lordosis. So kyphosis is the forward bending of the back, that is patient will be in stupor position due to deformity in the lumbar vertebra. Patient will be bending forward, and lordosis means the sideward bending of the patient due to some abnormalities in the vertebral regions. So in that case, we have to avoid giving this anesthesia, and it has to be also contraindicated if there is sepsis at the site of injection. If there is some infection or sepsis in the vertebral region, we have to avoid this spinal anesthesia. Now coming to epidural anesthesia. So epidural anesthesia, it is a method of administration of the local anesthetics in which a medicine is injected directly into the epidural space around the spinal cord, and here the placement of epidural catheter into the epidural space is done, which may remain in place for duration of the treatment. So it will cause loss of sensation and pain by blocking the transmission of signal from the nerve fiber in or near the spinal cord, and usually it is injected at the lumbar spine below the end of the spinal cord. So here local anesthetics is injected into epidural space where it acts on spinal nerve root, and it diffuses into epidural and subarachnoid spaces. So epidural anesthesia, it is also divided into three categories depending upon the site of injection. So where it is injected, either it is in the thoracic region or lumbar region. So depending upon the site, it is divided into three categories. One is thoracic epidural anesthesia. Here the small volume of drug is needed and is used to relieve pain following thoracic and upper abdominal surgery. If thoracic surgery is done, or if upper abdominal surgery is done, we can give thoracic epidural anesthesia. Whereas in lumbar region, large volume of drug is needed here, as the epidural space in the lumbar region is very wide. That's why we have to give large volume of drug in case of lumbar epidural anesthesia, and it produces anesthesia of lower abdomen, pelvis, and hind limbs. Whereas caudal epidural anesthesia injection is given in the sacral canal through hiatus through sacral hiatus. So it produces anesthesia of pelvic region and perineal region, and most commonly it is used for vaginal delivery, anorectal or urinary operations. So caudal anesthesia, caudal epidural anesthesia is usually given for vaginal delivery during pregnancy to have a painless delivery. Usually in developed countries nowadays they use epidural injection and to perform the painless delivery. In Nepal also they had tried once uh, to have the painless delivery, but nowadays they are not using it in practice. But it can be used to have painless vaginal delivery. It can be used for any anorectal surgeries or genitourinary operation, and the drug given here is lignocaine, bupivacaine, etc. So epidural anesthesia, this is the epidural procedure of epidural anesthesia. So here this is the epidural catheter. So we can puncture the epidural space, and catheter it is kept in that place until the duration of until the treatment is completed. For example, it can be kept epidural catheter can be placed in this site for longer duration time, in case like cancer patient. If patient is having cancer, as you all know, the cancer patient has very intense pain. So to relieve the cancer pain, epidural catheter is placed there, and patient itself can inject the uh, drug through the epidural catheter. So we can also give analgesic through the epidural catheter so that patient can have decrease in pain sensation like in cancer pain or any other major surgeries. Also epidural catheter is kept in that place, and patient can himself inject the analgesics through the epidural catheter. Now coming to last anesthetic procedure is the intravenous regional anesthesia. So intravenous regional anesthesia, it is also known as Beer's block. So in detail about Beer's block you will be taught during your clinical classes in anesthesia. So it is also known as Beer's block, and it is mainly used to anesthetize the upper limb while doing the surgery, and local anesthetic is injected directly into the vein of the limb whose blood flow is occluded by the tourniquet. So here you can see Beer's block. Okay, so where it is indicated is reduction of wrist fracture. For example, most common case where we use Beer blocks is during Cooley's fracture. That means the Cooley's fracture is the fracture of the distal end of the radius, which is known as Cooley's fracture. So to reduce this fracture, Beer's block are commonly used. Here what happens, local anesthetics like prilocaine is given in solution through the injection. And what is done here, tourniquet is applied here. So what is the procedure of Beer block is double cuff upper arm. So here tourniquet is applied, and the blood flow is occluded here by applying the tourniquet. And then after applying the tourniquet we have to elevate and accentuate the limb for 3 minutes. After applying the tourniquet we have to ask the patient to elevate the limb so that there will be no blood flow in this particular area, and blood will be there will be bloodless film in this area while doing the procedure. So we have to advise the patient to elevate the hand for 3 minutes, and then we have to apply the blood pressure cuff above 100 mm of Hg of systolic blood pressure, and we have to keep the blood pressure fixed above the 100 mm of systolic 100 mm of Hg of systolic blood pressure. So when we inflate the cuff and keep it in that position, what happens, there will be no supply of the blood in this area, and this particular area will be, the color will be changed into white color due to no blood supply. And after apply inflating the cuff to 100 mm of edge, we have to see the radial pulse. And when we cannot see the, when we cannot feel the radial pulse, then we have to inject the local anesthetic drug from the hand. Okay, so check for absence of radial pulse and then inject the prilocaine and check for adequate anesthesia. After giving the local anesthetic, we have to check for anesthesia by pinching the skin with the forceps, and we have to ask the patient whether patient is having pain sensation or not. If the patient says I'm not feeling anything or I am not feeling any pain sensation, then we have to perform the procedure, and after finishing the procedure we have to obtain the check x-ray. Okay, and the cuff must be inflated for a minimum of 20 minutes and maximum of 45 minutes, and watch for the signs of toxicity throughout. So you need not to know all these in detail. Now you will be taught about this during your anesthesia class during in the clinical. So I'm just telling you in brief so that you'll know later on. So after giving the anesthesia, we can do the procedure, whatever it has to be done in this patient. Okay, so this is the intravenous regional anesthesia, which is done by applying the tourniquet in the limb and doing the procedure. So this is all about the local anesthetic. So you have to know in detail about the spinal anesthesia, what are the contraindication of spinal anesthesia, and uh, and what are the most common adverse effect that is seen by giving spinal anesthesia. So this is all about the local anesthetic, and there are certain drug interactions, like if it is local anesthesia like lignocaine is given along with beta blocker propranolol, what happens, propranolol, by reducing the hepatic blood flow, it will impair the clearance of lignocaine. So there will be lignocaine toxicity. So whenever there is lignocaine toxicity, patient may have restlessness, increase in BP, etc. And another drug interaction is procaine. When it is given along with sulfonamide group of drug, procaine is hydrolyzed to PABA, and that reduces the effect of sulfonamide. So this is all about the local anesthetic drug. So hold on for a while, I'll take attendance.